So we're going to talk about elevated episcleral venous pressure. Recall that the vast majority of aqueous humor drains through the trabecular meshwork into the episcleral venous system. And as you can see in this Lee Allen painting, here's Schlemm's Canal going into the collector veins and then ultimately into the episcleral venous system. The normal episcleral venous pressure, and we'll abbreviate that ESVP, is 8 to 10 millimeters of mercury. So that's the theoretic minimum pressure you can get by increasing aqueous outflow through the trabecular meshwork. And each time you increase the episcleral venous pressure by 1 millimeter of mercury, in theory that would make the pressure go up based on the Goldman equation, where PV, episcleral venous pressure, adds on to whatever the formation and outflow is. Anything that impedes venous egress then can cause elevated episcleral venous pressure and therefore elevated intraocular pressure. One can have an arteriovenous fistula, either a dural sinus fistula or carotid cavernous fistula. And these are somewhat different. Dural sinus fistulas tend to be low flow. They can be subtle, although this one's not tremendously subtle. And we often see these in people who are elderly, who have vascular disease. Carotid cavernous fistulas tend to be high flow. They're often not subtle. They're often traumatic. Somebody who's had a very severe closed head injury, like this man who hit his boat into a log and knocked the boat motor up into his head. I don't like lists, but besides those two causes or AV malformations in the orbit, things that compress venous outflow, such as a mass or thyroid eye disease, orbital varices, Sturge-Weber, which we talk about in another lecture, and then this can be an idiopathic finding. The patients present usually with a red eye that is usually unilateral but can be bilateral. And some patients can actually hear swishing sound with pulsations in their head. So this is a gentleman who has a dural sinus fistula on the left side. You can see that the left eye is injected. He also has proptosis on that side, and just a closer view of his conjunctiva. So this is a usual appearance of somebody who has elevated episcleral venous pressure. Sometimes it's a little bit more dramatic, like this patient. And then on gonioscopy, one can see blood in Schlemm's Canal, and it's usually quite subtle, like it is in this patient. And for those of us like me who don't have great color vision, it can be a challenge to see. And sometimes it is not subtle, like in this patient. This is a patient with marked engorgement of the episcleral veins. And you can see on gonioscopy this tremendous view of blood in Schlemm's Canal. I must say that it's not usually this striking in my experience. It's often something you have to really look for. Just another example on video of a gonioscopy of somebody with elevated episcleral venous pressure, where you can see the blood in Schlemm's Canal quite easily. When you're checking intraocular pressure with Goldman applanation tonometry on these individuals, there's often a very big swing of the Myers against each other, showing the increase in pulse pressure. And some patients will have an audible bruit if you listen with the stethoscope. The treatment is to address the underlying etiology. If they have a fistula or an AV malformation or thyroid eye disease, the idea is to treat the underlying etiology. You can use aqueous suppressants to decrease aqueous formation. There is a theoretic advantage to prostaglandin analogs because they bypass the trabecular system and allow flow into the suprachoroidal space. But anything that increases access of aqueous to Schlemm's canal really is not very helpful, such as trabeculoplasty or cholinergic agonists. And if the pressure is very high, surgery on these eyes can be very risky. They can have suprachoroidal hemorrhage, they can have hemorrhage into the anterior chamber. This is a patient of mine from many years ago with a dural sinus fistula whose pressure was in the 50s, and at that time, radiologic intervention to try to close the fistula was very dangerous, so we did a trabeculectomy on this eye, and you can see that the eye just filled with blood. While this talk is on elevated episcleral venous pressure, there are other causes of blood in Schlemm's canal. You can imagine that if you lower the intraocular pressure enough, that the normal episcleral venous pressure would cause blood to reflux into Schlemm's canal. So you can see this with hypotony, and you can see it if you put excess pressure during gonioscopy on a lens that has a large area of contact, such as a Goldmann style lens. You can iatrogenically reflux blood into Schlemm's canal. So the key points: it's unilateral usually, but can be bilateral. There's a restriction of venous outflow due to an AV fistula or a malformation or mass effect that's impeding venous outflow. You can treat with aqueous suppressants and prostaglandin analogs, but the main treatment is to address the underlying disease.